Dr. Sabrina Siegel here with a special series brought to you by the NEI Podcast. Welcome to the PsychopharmaStahlogy Show. In this special series, Dr. Andrew Cutler interviews Dr. Stephen Stahl on the most controversial, novel, and exciting topics in psychopharmacology today. Every 3 months, we will address a different theme in psychopharmacology. Each theme is split into 3 parts, with 1 part released each month. This theme is on the future of psychopharmacology. This theme focuses on the updated 5th edition of Stahl's Essential Psychopharmacology, the 5E video series, effective strategies for learning about psychopharmacology, and what's on the horizon for the field. Let's listen in to part 3, the future of psychopharmacology.
Hello and welcome to another edition of the PsychopharmaStahlogy Show, a series of NEI podcasts. And now we are in the 3rd part of a 3-part series that is really related to the newest version of Dr. Stephen Stahl's textbook, Essentials of Psychopharmacology, that we're up to now the 5th edition. And I'm really looking forward to this conversation because I'm going to be talking with Dr. Stahl about the future of psychopharmacology. So, Steve, welcome.
Thank you, Andy.
Well, we have a lot to talk about. Let's start, before we get into the biology and the different drugs and things like that, let's start out with thinking about symptomatology and how, you're fond of saying people don't treat diagnoses, they treat symptom clusters. Why is this a helpful way of thinking about treating?
Because I think the diagnosis is a cluster of symptoms called a syndrome, and you really can't treat 3 things at once or treat them as a package. You treat each one individually. Now, it is true that some of our drugs work for lots of different symptoms in many patients, particularly easy patients, first episode patients, first-line treatments. And it's kind of remarkable that a single neurotransmitter, say like with an SSRI, serotonin selective reuptake inhibitor, would work at all, let alone on 3 or 4 different symptoms. But much more commonly, and the people listening to a podcast like this are worried about people who don't respond and who have residual symptoms or don't respond at all. And then what do you do? And so you generally want to, what I will sometimes say, construct a diagnosis, because that's how you get paid and that's how you communicate with other people and write notes. But in treatment, you then deconstruct the syndrome into its component symptoms. And if you're thinking the way that we're thinking in the future, and I think many of our people kind of do this intuitively already, they then think, well, wonder what the brain circuit is that mediates this stubborn symptom that I can't get rid of. Mm-hmm. And then what are the neurotransmitters that control the information processing's efficiency in that circuit? And do I want to block it or stimulate it? And then what drug do I want to use to work on the neurotransmitters? And so that's sort of the approach that people take, and particularly after an initial treatment fails to get rid of all symptoms.
Right. But isn't the danger here, Steve, much like a syndrome in medicine might be fever, chest pain, and cough? If I just use aspirin or acetaminophen to treat the fever, I'm not getting at the underlying pathology. I may actually mask something and make it worse.
I don't know whether the answer to your question should be no or hell no.
Right.
The reason for that is that in psychiatry, it's turning out that the symptom is the disease. And so, whereas you're right, if you have a tubercle bacillus in your lung or an E. coli in your bladder, and you have fever and take aspirin and the fever goes down, basically you're not done. And you have to go to the underlying cause. Mm-hmm. But really, it turns out that you could see psychiatric disorders as a bunch of disorders within the same person. Mm-hmm. So that if you have hallucinations and you have delusions, those are very likely, different symptoms and may respond differently in different circuits if you have problems with mood, etc. And so it turns out the reason that is even more powerful than that is that the symptoms beget symptoms. And so if you have a symptom and you don't get rid of it, the circuit seems to learn. I sometimes call it diabolical or evil learning. The circuit says, hey, I kind of like being inefficient this way, so I'm going to keep doing it. I got used to it. I'm kind of got a habit now. And so try and think about yourself. How many patients have you seen that have had a single panic attack or two, and you treat them, and how easy are they to treat compared to someone who has suffered, had incomplete treatment, has stopped treatment for a while, comes in 4 years later or 40 years later? How easy are they to treat? So circuits seem to learn how to have their symptoms. And so it seems like if we treated, until known otherwise, the symptom is the disorder. And you have a cluster of disorders, because each symptom being its own disorder, then we have to remove that, because each symptom is probably in a different part of the brain. You could say the brain is a thing, but the brain is probably, a number, at least dozens of circuits. And it's like there's dozens of brains, if you will, that way.
Yeah, it makes me think sometimes I've said, it's not schizophrenia, it's the schizophrenias. It's this heterogeneous group of things that maybe share certain clinical features. But the other thing you're reminding me of is, we used to think about abnormalities in a part of the brain, or maybe an abnormality in one neurochemical, too little serotonin or something like that. But that's not it at all. It's really about these circuits and about the regulation and the modulation of these circuits.
That's right. And something seems to go awry that we don't actually understand. It could be the compounding of nature and nurture, that if you have a bit of a chink in your armor genetically, but not enough to actually break down, all you have to do is add a load to that, and then it could break down. And the load could be from nurture, essentially from the environment. For example, what happens to someone who has child abuse? Oh my gosh, this does unbelievable stuff to the brain. So early life adversity, it can be called, whether it's physical, emotional, or sexual, or all three, that scars the brain and makes circuits very vulnerable to breaking down. If you have head trauma, if you then have substance abuse, if you have, problems with, other things, that the kind of people we see at the state hospital today have all those things combined. Plus, there's an underlying psychotic illness that emerges in the context of all these stressors, and it can make a difficult treatment, particularly of circuits.
Yeah, certainly true. I've sometimes thought a lot of people smoke cigarettes, but not everybody who smokes gets lung cancer. So there's obviously genetics to this. The same thing with, we give a lot of people antipsychotics, not everybody develops tardive dyskinesia. So there's a lot we have to learn, obviously, about the biology and the genetics of this thing. And it'd be nice if we could predict.
Yeah. I mean, one of the things I want to make sure is that people are not reductionistic in talking about chemical imbalances anymore, or serotonin in the brain.
Right.
Because serotonin at one receptor in one part of the brain is entirely different. Sometimes the opposite of serotonin in another part of the brain at a different receptor. So you're really talking about networks and nodes in networks, which nodes would be the connection between two neurons.
Steve, that's hugely important what you just said, because, sometimes people, I think, talk about serotonin receptors as this class, but, there's multiple different serotonin receptors that can do different things, but the same serotonin receptor can do something different in one part of the brain as another part, or presynaptically versus postsynaptically. It's really complicated, isn't it?
Yes, it is. And so instead of trying to be too reductionistic, the idea would be to be humble. And, part of that, you can fault me for being reductionistic in my own writings and teaching. It's only in the service of trying to make some rules about the brain and the disorders and how the drugs work, so that we can then understand the exceptions and then change the rules as we understand the brain better. Right. But for us to just say it's a black box and you throw drugs in there and you get better or you get worse, have a side effect or not, is not satisfactory. We have plausible hypotheses. So, I think that the issue would be, how do we move forward? How can we empower ourselves? And the idea is to actually treat each patient differently, so that you look at the bespoke sort of approach. Bespoke is an old, I think, 19th century term from the UK, where you had a bespoke suit was made just for you. There was not, machines making suits. 40 large or whatever. They took your own measurements. That's what we do in psychopharmacology.
Ideally, yeah, we want to individualize. You mentioned the symptoms and the circuits. Can you briefly review, I'm thinking of RDoC, of course, domains, but can you review maybe some of the symptom circuits that you're referring to?
Well, sure. I mean, basically, circuits go, around and around, but one of the nodes is one of the stopping points. So, a circuit goes from here to here to here, and each place as a nerve goes to one place and talks to another nerve, and that's a node. So one of the nodes in the cognition network, for example, is something that I've actually talked about in a rap song. The DLPFC, the dorsolateral prefrontal cortex. Mm-hmm. So that part of the brain is involved with executive functioning, and it has to do with problem solving. And other parts of the brain, like the VMPFC, the ventromedial prefrontal cortex, is involved with emotions and things like sadness or guilt. And so those are examples of nodes in networks. You have a node in the mesolimbic system that terminates in the striatum, and that's involved with psychosis. But it's also involved with reward. And so each node has a quite different function. And ultimately, every part of the brain is connected to every other part of the brain. But the circuits that are the most connected to each other, some of these we're beginning to see on various types of scans. You see the default mode and these other kinds of ideas of things that actually correlate with neuroimaging. We're not quite at the point we can look at the DLPFC's circuits, although you can actually have it light up in some cases if you do certain tasks. You put a load on it. So we're still at the infancy of being able to use neuroimaging to actually help us diagnostically in clinical practice. But the concept is how you just think about your patient. I mean, maybe I'm kind of a weird guy, but I'm sitting there looking at my patient saying, I wonder what part of the brain, this symptom's coming from. And I wonder what neurotransmitters are doing it. I've often used the analogy of guitar strings. You've heard me say that, where neurons that are running to another neuron, it's often a glutamate neuron is doing that, is firing and exciting a neuron downstream at another node. Well, coming up to talk to that glutamate neuron are fingers, if you will, on the glutamate neuron to tune it, just like you would tune a guitar string. And so you could tune it up, you could tune it down, and you're just as much out of tune if it's too high and too taut as if it's too low and too loose. So that's what we do for a living, is that we try to find these out-of-tune circuits and put the tuning fingers on the tuning bar. And if we're successful, we change the efficiency of information processing in a circuit, and the symptom goes away.
Yeah, and as we talked about, there are certain symptoms that cut across diagnostic categories. We talk, for instance, about irritability or cognitive impairment, or anxiety is another one that cuts across. Things like that. Well, now that we've kind of laid some of the groundwork, let's focus on really what the topic of today is, the future of psychopharmacology. And let's start out with, what are some areas that are some of the biggest unmet needs where we really need more treatments, more effective treatments?
Well, in general, of course, there are places where you have no treatment, or in places where you have treatments, but there's a lot of people who don't respond to those treatments. So some of the ways in which we hope to go, I hope this doesn't blow your mind too much, but the idea is, could we have disease modification where you actually change this diabolical learning I was talking about in the circuits? The circuits love to have their inefficient processing if you let them go on too long. How could you stop that from occurring? For example, is it possible that major depressive episodes evolve to major depressive episodes with mixed features of mania? Then they evolve to bipolar disorder with manic or hypomanic episodes, and then maybe they evolve to treatment resistance. If that's a pathway that some people take, how could we interrupt that? If, people have downstream consequences of inadequately treated illnesses, how do we stop that? And of course, Alzheimer's disease and neurodegenerative disease would be top of that list.
Yeah.
So stopping disease progression is one thing, but here's something. Hold on to your seat. How about prevention. How about stopping your first break episode of schizophrenia? Would that even be possible? Because I don't know how you could ever fix a schizophrenic brain once it started to be symptomatic. If patients have very serious illnesses, and you could, get symptomatic relief, and we do that, and maybe we can get even symptomatic relief of other unmet needs to answer your question in the negative and cognitive symptoms of schizophrenia. But what about if you took people at ultra high risk for schizophrenia and you prevented them from getting it? So people are thinking this way.
That would be amazing. And I've sometimes said, we don't have great biomarkers. We know about the schizophrenia prodrome, and yet not everybody who goes into the prodrome phase goes on to develop schizophrenia. Some go on to develop other things. So we really need a way to figure out who they are before we expose them to potential treatments with side effects.
Well, that's one of the big problems is the expense, but also none of the cost in dollars it's going to be the cost in burden of side effects. So we better be pretty certain it does. But we're doing that in, cardiovascular disease.
Sure.
The complications of hypertension, the complications of cholesterol, and trying to prevent diabetes. You can't really reverse that, maybe some of the worst stuff. But if you have prediabetes, getting out of that or preventing the progression to diabetes, this is well known throughout medicine. We have almost none of that in psychiatry.
It's so true. Yeah, we talk about primary prevention and secondary prevention, preventing further episodes and even tertiary prevention. We don't have a lot of primary prevention. You're right.
And so there are things that probably be unpopular. There have been, estimates that if you stop high potency cannabis use, there's a European study in Belgium or London, and would stop 30 to 40% of the onset of new psychotic episodes. So you just don't know who to stop it in because it's probably only 1 or 2% of the population. But if those people who are at high risk for schizophrenia take cannabis, it triggers it. And so we knew, but with a biomarker, who not to get cannabis, at least we could try to get them to not take cannabis.
Well, it's not just cannabis, right? Because the potency, as you mentioned, high potency, the potency today is much higher. The concentration of THC is something like triple what it used to be. So something we've talked about before, Steve, is the right dose. It's the exposure, the dose relationship as well.
Right. And drugs of abuse, have dose issues, not the least of which are things like fentanyl, which we're seeing laced into everything.
Yeah.
And fentanyl is so much more powerful than heroin that doesn't take much of a dose. In fact, a derivative of this carfentanil is something that is so potent that if you put it in an aerosol, you could spray it in an auditorium and kill everybody in the auditorium by just the amount that would get on your skin. So there are amazing problems with dosing of drugs. And as we get them more powerful, the more dangerous ones, of course, can be abused, and then we're in all sorts of trouble. What we want to do is turn that instead into figuring out how to dose things for the best risk benefit. And also, for example, if you avoid the bad stuff, let's say D2 antagonism, dopamine 2 antagonism in psychosis, it's possible for the future that we won't even have to block dopamine receptors. Why? Because we're beginning to understand the circuit. And the circuit has serotonin in it, it has acetylcholine in it, and has glutamate in it at least. And we're finding that if you use traceamine agonists, they will stop dopamine synthesis so you don't have to block it. If you use cholinergic agonists, it'll stop the overdrive of the dopamine neuron from stopping the upstream excitation of it. Same thing with serotonin. So there's very cool stuff happening that we never thought would be before. Whoever thought you could have a drug with antipsychotic actions that wasn't a D2 antagonist? Well, I just gave you 3 of them.
Mm-hmm. Yeah, that's remarkable because all roads may still lead to dopamine, but you're not getting the consequences of a direct dopamine receptor blocker, which of course can be devastating. Tardive dyskinesia, prolactin elevation, for instance.
Keeping up with the latest in psychiatry shouldn't be a struggle. SynovianFieldMedical.com is a new website for clinicians where you can find a library of free, hand-selected resources such as videos and infographics on important psychiatry topics. You can request an educational program for your practice or connect with Synovian medical professionals in your area. Synovian wants to help you get all of your psychiatry questions answered. Go to SynovianFieldMedical.com and explore what Synovian has to offer.
So we've talked a little bit about the future of psychosis treatment here. I mean, you've mentioned, a lot more than just dopamine. You talked about TAR1 receptors, which is the trace amine-associated receptor. Those are intracellular receptors. Most of our drugs work on extracellular receptors that stick out of the cell membrane, but this is a whole different kettle of fish.
Right, it actually didn't have a known function until we started to look at it. But, part of the issue about the future psychopharmacology is, Andy, headline, serendipity is back.
Oh, boy.
If you remember the first generation of antipsychotic and antidepressant drugs, they worked by accident. You had this drug for anesthesia or septic shock, or there's a lot of different stories about how it came out. It was called chlorpromazine.
Right.
And it calmed the patient. They use it in schizophrenia.
That's right.
And then the structure of chlorpromazine was changed a little bit, and it stopped blocking dopamine receptors, but it worked for depression, called imipramine.
Yeah.
So, that was the first generation of drugs.
Yeah.
And then that pooped out. And the second generation was what we grew up with in our trials and in our, practices with all the SSRIs, SNRIs, and even the so-called atypical antipsychotics in the 90s, really. And then the first decade of this century, again, was a slowing down of CNS innovation. And then we're now in the third episode, starting with things like TAR agonists, like you said, and stop dopamine synthesis, because we're going upstream. We're finding you can modify something by having the drivers of that thing at a node in its network at a distance from it. So it's in the same network, so the network is changing the downstream actions, and sometimes interacting at those nodes is softer and more tolerable than some of the things we're doing, and also will work in different people.
Yeah, absolutely. And so you're talking about serendipity. The whole way that drugs are discovered is evolving. It used to be pure serendipity. I mean, the lithium story I find fascinating. 1949, Cade in Australia doing work on gout, and he gave these guinea pigs lithium urate, and they got calmer, and he thought, at first, urate's making them calmer. And then he was smart enough, chance favors the prepared mind, is what Pasteur said. He said, what if I give them sodium urate? And they didn't get calm. So he, is really careful observation of serendipity. But then we kind of got better at sort of designing our drugs, as you said. But now the technology is amazing. I mean, the TAR1 agonist, for instance, one of the TAR1 agonists was discovered using this new technology called the Smart Cube, where, basically you give drugs to these animals and you study them and you look for behavioral cues of what the drug actually can do.
It's amazing. And what they did then was it predicted totally on animal behavior without knowing exactly what the drug did. It had no idea what receptor or enzyme it was doing at, but it made these drugs, the drug make the rats work like an antipsychotic would. So that company was bold enough to actually say, we're going to spend the money to actually go and ask humans with psychosis whether this works. And lo and behold, it did. So that is kind of the serendipity where, we've been humbled by a decade of fall off of innovation, because the real decade of the 90s was more or less full of making better versions of drugs that went to the same targets that the old drugs went to.
That's right.
So they were more precise and so forth, but they weren't really going to new stuff. Well, now we're having to go to new stuff because we've exhausted, particularly the monoamine system. And so how are we going to do that? Well, we're not clever enough to know what the targets are, but being a little bit sort of, if you will, humble about saying, we're just going to empirically test it. And if it works, we'll figure out the mechanism later. And that was how a lot of the stuff was done in the 60s. But we lost that because we were so darn smart, we thought, and did all these clever targeting. And all we got was 7 SSRIs and 15 atypical antipsychotics. And we don't need any more of either one of those. So we need something brand new.
Though, Steve, I've been doing clinical trials for almost 30 years. And, people say sometimes there's a lack of innovation in neuroscience, or there has been. I've seen a lot of innovative strategies and new mechanisms of action drugs fail, not because the drug doesn't work, but because it only works in a subset of people. And so the signal gets lost in the larger population. In my opinion, I think what we really have is a failure of biomarkers to really identify the right population of people that have the biologic process that the drug could be targeting.
Well, we kind of have an empiric biomarker by sort of accident. And that is, if you don't respond to 3 monoamine mechanisms, you have a non-monoamine depression, let's say.
That's right.
And so who knows what the biomarker is other than the fact that you have to grown through 3 of them. But in the old days, we would have, had you grown up at 20 or 30 years earlier, some Swiss drug company might have just given you a drug and said, Dr. Cutler, why don't you just screw around with this and tell us, what it works in. And then you find the subset of patients and can define it clinically. And so whether we have biomarkers soon or we just have clinical empiric definitions like failure of 2 monoamine mechanisms or something it's going to take, because we don't need another first-line treatment for many of our disorders, which are cheap and generic and function fairly well in many cases. What we need is things when those don't work or they don't work completely. And also for disorders with no treatment, as I mentioned, like the decline in Alzheimer's disease, which really doesn't have a lot of effective treatment that isn't at least controversial. And you don't have effective treatment for a lot of substance abuse disorders.
That's certainly true. And then there's other unmet needs too, like, of course, cognitive impairment in schizophrenia or the negative symptoms, which really are the things that impair people's function the most and have such devastating impact on their lives. So we can treat some symptoms.
It's not the psychosis that keeps somebody from having a good outcome. It's the cognition and the apathy that really is more related to functional outcome in schizophrenia than even these dramatic voices and so forth.
Yeah. And people are definitely working on treatments for cognitive impairment associated with schizophrenia. They call it CIAS, and people are working on treatments for negative symptoms of schizophrenia. But, there's difficulty in picking the endpoints in a clinical trial. How do you measure and how do you decide if this thing is working for this thing or not? That's also been an issue.
That's right. And the treatments that have been done so far have improvement, which are not much bigger than the effect size of practice. So if you test somebody pre and you test somebody post, they practiced. And so that alone increases it without a drug. And so this is part of our problem. We haven't found things that are dramatically different. But, the issue is that if you have to say, we're so clever, we know the target and we have to hit this target and we're going to put that in all schizophrenia patients, to your point of no subsets, that's destined to failure. What you have to say is we have probably no idea, have some hypotheses, but let's put in a drug with a known mechanism and see what it does and be much more hypothesis generating than thinking we know how to confirm a hypothesis in phase 2 when we haven't really got much experience with the drug at all.
Yeah. Well, really, as I was saying before, I feel like there's been a little bit of a failure of biomarkers. And biomarkers can be not just drawing a tube of blood and maybe genetics or something in the blood, but it can be clinical biomarkers, as you mentioned, certain clinical phenotypes, certain symptom clusters. But nowadays, with the advance of technology, it can be digital biomarkers. So there's some real amazing stuff going on in drug development with technology, looking at, for instance, the way we use your smartphone. Your smartphone is a wealth of data that can be captured. And I've been seeing protocols for clinical trials now where your smartphone is a GPS. It can tell you where you are and how much you're moving around. It can tell how often you're interacting with other people through texting and through phone calls and emails. It can even, with using the front-facing camera, you can actually have somebody interact with the cell phone and the software is monitoring your facial expression and the prosody of your speech. So I can imagine that the whole area of how we evaluate drugs and maybe find certain drugs working for very specific subsets of symptoms is going to evolve.
Yes. And some people call that, phenotypes or and phenomics, if you will, as opposed to genomics.
Mm-hmm.
And the phenomics is the description of the behavior, which can be captivated digitally.
Yeah, digital phenotyping is what I've seen some people talk about. All right, let's get into a couple of specific areas. You had mentioned substance abuse earlier, and I want to circle back to that because really with the COVID-19 pandemic, there has been such we all knew that substance abuse was a big problem, but it has exploded even more. And we've got more people now using drugs. We've got more people dying from overdoses. You mentioned another problem, which is that more and more of these drugs are laced with things like fentanyl, which are super high potency and can lead people to die. Where are we with treatments for substance abuse?
Well, in a bad place. I think that the future of psychopharmacology has to start with at least using the therapies that are there more frequently. Studies show that a distinct minority, maybe, a few percent at most, are people get the treatments that are approved for alcoholism or opioid abuse, for example. And so why we don't use the ones that are available is a bit of a question the first way. But we're going to rely on translational neuroscience from rodent and primate models because we're beginning to understand that this kind of action of substance abuse, which is really a form of learning. Plasticity. When you take a drug of abuse, you first get joy, and then you get addiction. And addiction is not really joy. It's maybe stopping the misery of not having the drug, but it's also kind of like being a robot or some sort of a Pavlovian dog where you walk through life and now you've been conditioned to drink whenever you see, a bar, or whenever you smoke a cigarette, because it's an association. It's called, selective attention. And so you pay attention to those things that are associated with your substance abuse disproportionately, and it triggers the desire to abuse the drug. So we have to unlearn you. And so the treatments can't just block the joy of drug abuse, because by the time how many people are having a lot of good time with their heroin? If you've ever seen a heroin addict out there or a stimulant abuser,
No.
Deep into the illness, they're miserable, even on drug. They're trying to be less miserable, but they're not really in joy. So how do you actually reverse the plasticity that has changed? Their brain has really been altered so that they're almost unable. It's just hard for people to believe, well, just stop, right? They can't stop. It's involuntary at this point. So how do we reverse this habit learning, you could call it? And so that's part of the future. And we're learning how to do that in animal models. And as soon as we actually have some ways to do that, they're very likely to translate into humans because, an addicted rodent or primate brain is very similar to an addicted human brain.
Yeah, it's interesting.
I think there's great hope in the next decade or two.
I hope so, certainly. So let's shift over to mood disorders. What are some of the new things on the horizon for mood disorders?
Well, they all play, at this point, the most immediate ones that are going to come out on the so-called NMDA, N-methyl-D-aspartate subtype of glutamate receptor. Famous, of course, are ketamine infusions and S-ketamine intranasal. But the problem with that is it doesn't work for everybody. It doesn't work for very long. It is hard to give. It's expensive. You have to stay in the office or the clinic for hours afterwards. You can't drive. And repeated dosing is difficult. But now we have at least 2 pretty well advanced oral treatments that are oral NMDA antagonists that have positive phase 2 studies. One of them, of course, is the combination of dextromethorphan plus bupropion, which actually went to the FDA, and they, at this current time of this recording, have not said why they haven't accepted it for, approval, but it's been delayed, and so we don't know. But if you just look at the statistics and the design of the study, it looks like it's positive, and several studies have been, both for regular depression and for treatment-resistant depression. So, have to basically hold on and wait to see what happens there. And the other one is the inactive opiate inactive enantiomer of methadone.
Methadone?
So F-methadone is, Methadone itself is an NMDA antagonist, but also a mu opioid agonist, which, by the way, is ketamine, and so is dextromethorphan. But they're weak, and you can take the potency of methadone's, powerful mu opioid agonist actions out by taking the so-called inactive enantiomer, and it's a pretty good NMDA antagonist, even though it's no longer a potent opioid agonist. And what that does is it has caused rapid onset antidepressant effects as well. Actually, the paper at this time of our recording today has been accepted in the American Journal of Psychiatry. There's a co-author on that. So there's a positive phase 2 study, and of these 2 oral NMDA antagonists, and there's others in the pipeline behind it.
You just said something, though, that makes me realize we're not just talking about innovations in the mechanism of action of drugs. This is a whole paradigm shift, the concept of rapid onset of efficacy. Instead of waiting 4 to 6 weeks for a monoaminergic drug to work, these NMDA antagonists, and I'm sure we'll be talking in a minute about the GABA A receptor modulators, these things can work within, in some cases, hours or days.
Amazing, isn't it?
It's amazing.
And this actually kind of relates to the potential use of the psilocybin-like agents, because what do all these rapid-acting agents seem to have in common? They are neurotrophic, and they cause neurite sprouting. So the ends of your neurons start to make connections within minutes of infusion or taking it. And it's thought, we don't know, but it's the time is at the same time you get better. We're thinking that formation of connections is what is the therapeutic action. And in fact, the monoamines do it, but they do it in 4 weeks.
Right.
So, the issue is, what is it about these drugs that do it and do it fast? And so we could have rapid onset, possibly by synaptogenesis. We don't really make more neurons. We make more connections to neurons. With all these drugs, share that.
Amazing. And you mentioned psychedelics. I definitely wanted to go there, too. There are a lot of studies now, a lot of studies going on looking at psychedelics for a variety of conditions. What can you say about that?
Well, I'm kind of a skeptic about that approach for a number of reasons. If you look at some of the data that are out, it's not clear that you have to hallucinate or have a psychotic or sort of dissociative experience in order for this to work. Right. If you talk to people, though, who have had ayahuasca or had psilocybin, some of the most powerful advocates are just swearing up and down that was a really, 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 really meaningful experience for them. And that is really what was helpful. But actually, when you deal deep in that, I've seen several of these patients, they're not better. They've had a great experience. But, I haven't been impressed necessarily with how well their depression or their PTSD got better. But boy, they think that you have this thing. So some people are chasing that, which is saying, let's give psilocybin, but what we want to do is make it legal. Let's give ecstasy, but let's make it legal. And what we're going to do is spend 4 hours in psychotherapy with you, and then that's going to cure you, because it's really the crazy experience that you have combined with my charisma as a therapist is going to fix you.
Yeah.
Well, this is maybe. But all these, by the way, all these drugs cause neuroplasticity, and you can, there's 2 small companies at least that are looking at drugs that have the neuroplasticity of psilocybin, but not the hallucinations. So if that's the case, then you could take an oral drug that doesn't require hours of psychotherapy, and that would be really, again, if you will, a ketamine-like or an NMDA antagonist-like agent. That's the future.
So you're talking about microdosing of psychedelics? Or a totally different
well, it's not necessarily microdosing. I mean, people have talked about that, but their dosing is sufficient to occupy, in this case, sufficient numbers of 5-HT2A receptors. So it's not really a microdose. By the way, I'm actually on a panel for this upcoming APA that was put together by Joel Dimsdale, who's a professor at UCSD where I am. He wrote a book recently called Dark Persuasion. And in it, he reminds us that psilocybin was used by the CIA, if you don't recall, and it was used for bad purposes because it tried to do 2 things: either brainwash you to believe something that you didn't want to believe or tried to reject when you were conscious, or it was a truth serum, if you will, to make you give up in confessions. And they weren't all that successful at it. But the point is that when you're playing with fire, like trying to change the memories of people under therapy and under intoxication, be careful. Yeah. Because it's not always good stuff that can happen from that. We don't really know what we're doing. The idea, though, is that you have bad memories all the way back to Freud, and that if you purge those memories, whether it's a memory of an explosion and a PTSD or something else, and that if you replace that memory, it would be good to do, and that would be, heroic, noble, and kind, and that you would then be cured. But be careful, that's all.
I want to be open-minded, Steve, to these new ideas and new concepts, but I share a little bit of your skepticism here. It just doesn't make a lot of sense to me that, one or two of these treatments is going to induce this long-lasting change, rewire the brain or something.
Well, it's also not going to be generally available because, the people that are going to be able to afford to have a psilocybin experience and 4 hours of psychotherapy, this is all done at high-end clinics that are cash paying, be thousands of dollars. And the capacity of being able to do this with a number of patients, it's not going to have experience. Although, there's companies that are trying to do this, and there's billions of dollars are being raised already. And so maybe I'm wrong, but I would rather have there's this term called a psychoplastogen, which these same drugs are psychoplastic, and they don't necessarily need psychotherapy, which we don't know what we're doing anyway, and they don't necessarily need you to be hallucinating.
Mm-hmm. Right. Yeah, I'm a little worried too. There's regulatory hurdles because they're Schedule I drugs, which is a whole layer of regulatory hassle. And then the fact that how do you monetize these things? These drugs have been around forever. They're generic. So, are you monetizing, like you said, the experience, the therapy, and then the clinic itself?
Right. I just don't get it. The model is. The model is to charge people a lot of money for the therapy and give the drug, which will be generic, for very little.
Okay, well, there's some of the other things in development for mood disorders. I'm sure you're following the story of the mTORC1 activator, a company called Navitor. We think this is in that pathway of how ketamine works rapidly. That mTORC is somehow, inducing synaptogenesis and dendritic sprouting. So there's a drug being looked at for that. That would be interesting. There are drugs that are TrkB receptor agonists. That's the receptor that BDNF binds to. So again, thinking that we could influence the synaptogenesis through that mechanism. So people are trying to deconstruct the ketamine mechanism of action and pathway and go further upstream even. Very interesting.
Yeah, I think neuroplasticity in the right place at the right time is a therapeutic goal. And all of these things, there's a limited number of things that make your brain grow new synapses. And if we could harness them, there may be many ways to get the same outcome.
Well, there's really, you're getting me to think of the two sides of the same coin. There's these drugs that are working on neuroplasticity. And as you said, not all neuroplasticity is good, so it has to be targeted. But it's not only neuroplasticity, but it's also defeating inflammation. So it's anti-neuroinflammation, which obviously does the opposite and destroys synapses and neurons. There's a lot of people working on anti-inflammatory kinds of mechanisms as well. And it could be that some of our effective drugs do have anti-inflammatory properties. That may be part of how they work.
Yeah. Well, what's this thing? Fluvoxamine was found to have effects of COVID as an epiphenomenon of its serotonin reuptake blockade that just blew people away. Yeah. So maybe similar things are happening, and it would be pretty amazing if we could harness this. Again, you have to be careful because some of these mTOR pathways are being targeted by cancer chemotherapy because they're making things grow that you don't want to, called cancer cells.
That's right.
And so you have to make sure that you're growing the right stuff and it's not dangerous. And so you have to be humble and be careful.
Well, there's a class of drugs that are in development too called HDAC inhibitors, the histone deacetylase inhibitors. They regulate epigenetics of the immune system in particular. And you're right that some of these drugs are being used for cancer, some are being looked at for neurodegenerative conditions and even depression, but they have such wide-ranging effects, it's really hard to harness the system. The other thing that's interesting...
Well, the issue is it changes epigenetics maybe where you want to, but also where you don't want to.
Right.
For example, one of the HDAC inhibitors is a thing called valproic acid.
That's right.
And so,
Right.
what does that do to fetuses and what does that do to the brain? Maybe it's good to people with bipolar. Maybe that's part of its mechanism of action. But obviously, it can have some bad effects too.
Another area of intense research and certainly clinically relevant, because patients ask us about this all the time, is cannabinoids. And certainly people are looking at THC and CBD and all these other things. But there's another class of drugs too that inhibit the metabolism of anandamide, which is an endocannabinoid. So these are FAAH inhibitors. These are fatty acid amide hydrolase inhibitors. It's the enzyme that breaks down anandamide. And the thinking is by doing that, you get the benefits of binding to CB1 or cannabinoid receptors without the collateral damage, the side effects of exogenously administered cannabinoid agonists like THC.
You mean you can get high without inhaling? I mean, you're right. The brain makes its own marijuana, if you will, or cannabinoid,
Exactly.
and it does it for some good reason. It's a retrograde neurotransmitter, and it's not clear how that could be used therapeutically. The problem with the cannabinoids is that is dose and basically purity.
Right.
There are 500 alkaloids in the average cannabis plant, and one plant to another doesn't have the same ones, including some alkaloids that are basically things like pesticides. Having that and knowing how much you're getting and what you're getting is the hallmark of pharmacology. So you can't really do dose response curves because you have different amounts and you also have different composition. So there have been some approvals for THC that's purified, and there may be some that come for CBD that's purified. But taking cannabinoids in smoke that you get at a marijuana shop is going to be very difficult to ever show, definitively how it works because it's not being studied like a drug.
Yeah. Yeah, that's why I'm fascinated by this concept of inhibiting the enzyme that breaks down the endogenous cannabinoids. There's some evidence we could be talking about an anti-inflammatory, analgesic, anxiolytic, antidepressant. There's all these things that people claim that cannabis helps them with. But see, nobody really knows. All right. Moving on to another unmet need that we talked about. How about some of these newer agents to treat agitation and behavioral symptoms of Alzheimer's disease? How can these drugs, how can a multimodal drug work? How can an NMDA antagonist work for that?
Well, there are two drugs in late stage development for agitation and Alzheimer's disease. Agitation, of course, is one of the so-called behavioral symptoms of dementia. And as we fail to treat the causes and prevent or reverse Alzheimer's, which we are failing to do, it looks like, well, then we're going to have a lot more people and they're going to have behavioral symptoms. And psychosis is one, which is under investigation by one mechanism, like serotonin 2 antagonism, and agitation is the other by two different mechanisms. And it turns out that they get back to these circuits. There's a circuit for psychosis, there's a circuit for memory, there's a circuit for agitation, and they're in parallel. But part of that circuit dies in Alzheimer's disease.
Right.
And in the case of agitation, top-down inhibition of bottom-up drives gets lost.
Right.
So somehow you've got to replace that. And it turns out empirically that if you have alpha-1 antagonism, perhaps is one of the most important because, as you know, alpha-2 antagonism as well, those two agents are useful for agitation in their own right.
Right.
Things like some new drugs in development for schizophrenia work in agitation, but they can be sedating. This drug that we're talking about that does the multimodal is a well-known antipsychotic called brexpiprazole, and it has 2 or 3 positive trials. It's in late-stage development. They may get approved within months, and it works by both alpha-1 and alpha-2 antagonist properties, but also by 5-HT2A antagonist properties and even 5-HT1A agonist properties. Not to speak, of course, it's also a D2 antagonist. So it's thought that this drug actually works that way, and it has a very good effect on the way you can measure that. So there's no question it has efficacy. The other one is a drug called AX05, which is a combination of dextromethorphan plus bupropion, which is the drug we already talked about, which is showing good signs of working in both depression and treatment-resistant depression, and it blocks the glutamate excitation of cells and maybe prevents this loss of top-down inhibition. So whatever it is, both of these drugs seem to be in late stage with good efficacy and might even be used together because they have complementary mechanisms.
That is fast. Goodness. Well, we've really gone a long way around this concept here, the topic of psychopharmacology. And again, I hope that we transmit to the audience, Steve, our enthusiasm here. For a while there, I have to be honest, I was getting a little jaded. I was getting a little frustrated that there just wasn't a whole lot of new stuff coming out in our field. And as you said, some of the big pharma companies abandoned CNS drug development. They're all coming back now, whether by themselves or by funding small biotechs and startup incubators. And all of a sudden, it seems an incredibly rich and fertile environment with a lot of new targets, a lot of new things on the horizon. So it's a very exciting time for clinicians, wouldn't you say?
Absolutely. It's a great time to be in mental health. I think the future is going to change dramatically. There's so much in the pipeline. And in fact, some people have said that it's replacing cancer chemotherapy as the most innovative chapter in all of medicine. There's a lot of, but it's funny, it comes in very small companies. They're often one-trick ponies. They're doing,
that's right.
All their bets are on one drug with one mechanism, and a bunch of them fail, but the ones that make it then get bought by the marketing companies, which are really just big pharma as a marketing company. And I think that, watch out, hold on to your seats, keep your seatbelt on, because we're blasting off. There's going to be all sorts of new stuff in the next decade.
I agree. So thank you all so much for your listening to us. And hopefully we've given you some food for thought. We've given you something to make you go to the literature and use research tools like Dr. Google and look up some of the things we're talking about, stay abreast of the latest developments. And I really think the pace of innovation is accelerating. And really within our lifetime, we're going to have some exciting new treatments. Thanks so much. And remember to listen to the other podcasts in this series, the PsychopharmaStahlogy Show, NEI's podcast series. And this has been part 3 of a 3-part series that really is the impetus was the newest edition of Dr. Stahl's textbook Essentials of Psychopharmacology. Thanks for listening and hope to see you again soon.
Thank you so much for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.